Alrighty, welcome everyone. I'm ChicagoDLSinc. I do group sessions and one-on-one tutoring for the Naplex and the MPJE. You can send me a DM or a direct message if you have questions or concerns. And if you've taken the Naplex before and have a score report, I'm happy to provide you feedback. And if you haven't, but you've taken an assessment and would like some direction, I'm happy to provide that also. Today we're going to do a mini lesson on angina or angina, and the resources I use are RxPrep and Pass Naplex now. These are considered mini lessons, which means there will be information that you will have to look up later or on your own, and this is by no means comprehensive. If you have any questions or concerns, I'm happy to answer them at the end of the presentation, and there will be 4 practice questions. So let's go ahead and get started. Uh, Real quick, shout out to Suspicious Bunch and Pharma Turtles, who are the mods of the servers for facilitating this. And there are surveys if you are new. Please fill them out so we can use your feedback to improve. All right, so I pronounce it angina, and it is a sensation of heavy chest pressure, and this is due to insufficient oxygen delivery. This insufficiency is in the coronary artery system, that is the blood supply of the heart, and it can be secondary to many reasons, including coronary plaques, coronary artery spasm, or increased workload. Occasionally radiates to the left shoulder or the left arm as the heart is on the left side, as well as it shares innervation. It can also radiate to the jaw. Anginal pain lasts between 30 seconds to 30 minutes. The ECG or the EKG might show ST segment depression greater than 2 millimeters. And if ischemia is severe enough to cause the death of myocardial cells, then it is considered an acute myocardial infarction, aka a heart attack. So there are 3 main variants of angina. Stable, this comes with extra activity or emotional stress, and it's resolved with rest or nitroglycerin. Unstable angina is chest pain even at rest and does not resolve with nitroglycerin or changing positions or resting more. Vasospastic, I don't think they call it Prinz metals anymore, but every now and then the name will pop up. It's also known as variant angina, and this is due to coronary artery spasm. Doesn't have any triggers and often occurs overnight. So, treatment summaries for these for chronic stable angina, which is also known as exercise induced. Nitrates, sublingual nitroglycerin is the drug of choice for acute management, acts in 1 to 2 minutes. Beta blockers, first line for most with chronic angina, and that's going to also include calcium channel blockers, and then ranolazine or Ranexa. Unstable angina is a medical emergency. Does anyone know what the acronym MONA stands for? MONA? If you do, please type it into the chat. Once again, the question is MONA, MONA. What does that stand for? And if you don't know, that's okay. I will go over it. NTG is going to be nitroglycerin sublingual, followed by IV nitroglycerin. Beta blockers IV as well, most commonly metoprolol or atenolol. All right. Last but not least, vasospastic angina. We use nitrates, sublingual as needed, and then calcium channel blockers are first line therapy. We have verapamil, diltiazem, and nifedipine. Great job. Morphine, oxygen, nitroglycerin, and aspirin is MONA. And you'll also notice in the treatment of acute MI, we also use MONA as well. All right. So nitrates, we have a mechanism of action. They decrease the myocardial oxygen demand, by vasodilation of the peripheral veins and arteries. They decrease preload and they decrease afterload. Remember, preload is what's coming to the heart, and afterload is what the heart is pumping against. Adverse effects are going to be flushing, hypotension, dizziness, and lightheadedness. And orthostatic hypotension resulting in headache is most common. So we counsel the patient to take sublingual nitroglycerin sitting down. You need a 12 to 18 hour nitrate free period each day to avoid tolerance. Now, different books and different sources may have different times. Just keep that in mind that there needs to be a prolonged nitrate free period to avoid tolerance. Monitoring parameters for nitrates, we're going to do blood pressure and heart rate. Now, interactions that you need to be aware of. Alcohol can increase the lightheadedness. There can be fainting with antihypertensives and alcohol. Now, it is contraindicated with sildenafil, tadalafil, vardenafil, and avanafil. Excuse me. Can anyone tell me in the chat what class of drugs, sildenafil, tadalafil, etc., they belong to? What class of drugs? All right. And there are timelines, so within 12 to 48 hours, depending on which PDE5 inhibitor you are taking. That is correct. Great job, everyone. Great job on the MONA and great job on the PDE5. So we also avoid nitrates when there's hypotension, systolic is below 90, or there's marked brady or tachycardia, and also in right ventricle infarction. The next slide has nitrates, routes, and brand names or routes, potato, potato. And we have IV, we have tabs, we have sublingual, we have sprays, we have powders, transdermal patches, ointments, and a rectal ointment. The last one for anal fissures, these are tears in the anal canal. They are not pleasant. Next, we have beta blockers. Now, in both RxPrep and Past Naplex now, going back to the different types, there are review cards for each form that is tested. And most of the nitrates are high yield. Please do go back and review them. When we do this again in a few weeks, I will probably add those slides. So beta blockers, they're the first line for patients with chronic angina. Vasospastic are not indicated, and in fact, they can induce coronary vasospasm. All beta blockers appear to be equally effective for chronic. And their effects are going to be they decrease heart rate, they decrease myocardial contractility, and they also decrease afterload. Beta blockers overall reduce oxygen demand of the heart. So let's talk about calcium channel blockers. On the right, you see a picture of verapamil hydrochloride. So for stable angina, all calcium channel blockers are effective, and they can be added with beta blockers or they can be substituted for beta blockers if the patient is unable to tolerate beta blockers. So long-acting diltiazem or verapamil is good. Also adding a long-acting second-gen dihydropyridine such as amlodipine is also important. Can anyone tell me a brand name for amlodipine in the chat? Brand name for amlodipine. For vasospastic angina, it responds well to calcium channel blockers and nitrates. Calcium channel blockers are going to be first line. And the common ones are going to be verapamil, diltiazem, and nifedipine. All right, those of you that answer Norvas, that is correct. Now, suspicious bunch in the resource section has shared a link for the top 200 and top 300 brands and generics. I always recommend to everyone that I work with, whether you're a first-time test taker or are repeating, 300 brands and generics are very important. Now, some you'll remember because you've either taken them or have some sort of clinical association with them. You do need to know them. Some Naplex questions will have all brands, some will have generic, some will have a mix. Okay? So, continuing calcium channel blockers, on the left we have a picture of diltiazem. Verapamil decreases myocardial oxygen demand by acting as a negative inotrope and a negative chronotrope. It is a less potent vasodilator than dihydropyridines, and therefore the side effects or adverse effects of headache, flushing, and peripheral edema are less. Diltiazem has actions that fall between verapamil and the DHP CCBs, the dihydropyridines, and the FDA-approved dihydropyridines are going to be amlodipine, nifedipine, and nicardipine. Important note, the short-acting immediate-release nifedipine is limited by reflex tachycardia and peripheral edema, flushing, and headache. Excuse the typo. These symptoms are reduced with long-acting extended-release nifedipine or the second-gen DHPs. Now we have ranolazine, aka Ranexa. Uh, this is used as a substitute for beta blockers in chronic angina, and if the beta blockers are ineffective, contraindicated, or have unacceptable adverse effects. It can also be used as an add-on with the beta blockers, calcium channel blockers, or nitrates. It is not more effective than other options. It is a substitute or an add-on. So basically consider it second line or third line. Ranolazine does not lower BP or heart rate, and it may prolong the QT interval. So you have to have baseline and follow-up electrocardiograms. The dose is going to be 500 mg BID. Maximum is going to be 1000 BID. And remember that Ranexa is a CYP3A4 substrate. So inhibitors of 3A4 will increase it. Maximum, if there's verapamil or diltiazem also prescribed, is going to be 500 milligrams BID. So on the right side, you'll see a Ranexa 500 milligrams. This is a prolonged release box. And the side effects are dizziness and constipation are the most common. And with uncorrected hypokalemia, or if there is uncorrected hypokalemia, there will be pre-existing long QT. That's going to be an extreme caution or contraindication. Hepatic impairment, patients are more prone to QT increase. And if they're already on QT prolonging drugs like quinidine, dofetilide, sotalol, thiaridazine, or ziprasidone. Can anyone tell me an antifungal that can prolong QT interval? Once again in the chat, an antifungal that can prolong QT interval. And if you're not sure about an antifungal, what about an anti-allergy medication? I'll accept either or both. And if they're on CYP3A4 inhibitors, such as azole antifungals, diltiazem, verapamil, macrolides or macrolides, protease inhibitors, and grapefruit juice. For those of you that do not know, grapefruit juice, as sour, acidic as it is, has tons of sugar in it. Just an FYI. All right, anyone else on antifungals that can prolong prolong QT and or an anti-allergy? Good job, TZ. Good job, Nikki. All right, Allegra, aka fexofenadine, can prolong QT Fun fact, I took it all through high school and I'm okay, but I avoid it just 'cause. All right, very good. Let's continue. So to review for chronic stable angina, beta blockers are the first choice. Your CCV choices are verapamil and diltiazem, long-acting nitrates such as the extended release patch, Q daily, and ranolazine. All patients should have a rapid-acting nitrate such as nitrostat, nitrolingual, nitromist, or go nitro. Remind the patient to call 911 for an acute attack if there's no relief within 5 minutes after the first dose. And every 5 minutes, continue using nitro up to 2 more doses. Next, we have vasospastic angina review. So calcium channel blockers are going to be first line. Once again, verapamil and diltiazem. And long-acting nitrates for those patients that don't have acceptable improvement. And you could do isosorbide mononitrate 30 or 60 mgs once a day. And then once again, all patients should have a rapid-acting nitrate for acute angina. All right. So I have 4 practice questions. And for those of you that are new, I'll read the question. And then in the chat, you can put your answer choices. If you're not sure, feel free to guess or put a question mark next to it. And make sure that if anything we've covered so far or in the practice questions you notice you're unaware of or unsure of, go back and review either today after the session or tomorrow. Same thing with your Q banks when you review your incorrects. The sooner you review, the quicker or the better you retain this information. So remember, the amount of information that you have to know for the Naplex is quite fast, and you want to be able to retain it. Afterwards, you might forget it all, but that's a whole nother story. So let's start with practice question 1. Which of the following is not true regarding the use of long-acting nitrates? A. They can be given with or without food. They are not used for acute relief of angina. C. Monitoring blood pressure is warranted while on therapy. Choice D. Can be used safely with PDE5 inhibitors. Give everyone a chance to answer. Okay. Looks like everyone chose D, and D is correct. Concomitant use with PDE5 inhibitors such as sildenafil or tadalafil can lead to severe hypotension and an increased fall risk. Great job, everyone. Anyone have any questions or concerns about practice question 1 so far? All right. If you think of a question later, feel free to put it in the chat or send me a message. Practice question 2 says a 58-year-old male is rushed to your ED with complaints of chest pain. He is diagnosed with unstable angina. Which of the following assessments would be most appropriate to determine the likelihood of a cardiac ischemic event and help determine the urgency for further intervention? Choice A, Chad Vask. Choice B, Timmy. Choice C, PHQ-9. And choice D, Curb 65. If you don't know, it is okay to guess. Give a couple more seconds if anyone else wants to attempt this. All right, good. So B is the correct answer. Now B is thrombolysis in myocardial infarction. And this is the most important assessment to determine the likelihood of a cardiac ischemic event and help determine urgency. Now let's break down the other choices. PHQ-9 or choice C is a screening tool for depression and the severity of depression in adults. CURB 65 is a clinical prediction rule used to assess the severity of community acquired pneumonia or CAP in adults to determine the need for hospitalization. So, um, however, there's some discussion. There's also a tool called PSI, Pneumonia Severity Index, and depending on who you ask, they may say that one is better than CURB 65. Okay. The CHA2DS2-VASc score is a clinical prediction tool to assess the risk of stroke in patients who have AFib, atrial fibrillation. So the score is used to guide decisions about anticoagulation therapy, with higher scores indicating a greater risk of stroke and thus a greater potential benefit from anticoagulation. All right, for Archer, good job. TZ, good guess. All right, let's go on to practice question 3. This one is a little longer. It's also a select all that apply. So, CJ is a 62-year-old male who presents to your pharmacotherapy clinic with complaints of worsening chest pain. The patient reports experiencing chest pain radiating to both arms while lifting heavy boxes at work. Additionally, CJ states that his chest pain seems to resolve once he rests. Past medical history is significant for hypertension, dyslipidemia, erectile dysfunction, MI from 2 years ago, GERD, CHF class 3 with an ejection fraction of 30%, and type 2 diabetes. Current medications include Zestril 20 mg daily, Zocor 80 mg daily, Protonix 40 mg daily, Actos 15 mg daily, and Levitra 10 mg daily as needed. After meeting with his provider, CJ is diagnosed with typical angina and is started on Isordil 10 mgs at 8 a.m. and 4 p.m. each day. No known drug allergies. A1C is 8.5%. Creatinine clearance 97. Serum creatinine 0.9. BUN 14. Chloride 103. Potassium 3.6. Sodium 137. Vitals are overall stable. Weight is 87 kilograms. Height is 67 inches. Which of the following changes would be appropriate to make to CJ's medication regimen? So remember, this is a select all that apply. It can be one, it can be all, it can be any in between. Both RX Prep and Past Naplex now do a great job in not setting any patterns. There are no patterns. If you got 3 right in one, then it's 2 or 4 in the other. It can be any. Excuse me. So A, discontinue Actos 15 mg daily and initiate metformin 500 mg BID. Choice B, initiate enteric-coated aspirin 81 mg daily. Choice C, discontinue Levitra 10 milligrams daily PRN. Choice D, discontinue Zocor 80, initiate Crestor 20. And choice E, initiate Cardizem CD 120 mgs daily. All right. So let's discuss this. The correct answers are going to be A, B, C, and D. And let's actually start with choice E, why it's incorrect. So cardizem is the brand name for diltiazem. And diltiazem, as you know, is a non-DHP calcium channel blocker. And we're going to avoid these in patients with systolic heart failure because it has negative ionotropic effects. With the injection fraction already being 30%, diltiazem would be inappropriate for this patient. A better choice would be a beta blocker, such as metoprolol, carvedilol, or bisoprolol. So that's why choice E is out. Now let's talk about D. With a history of CHF, diabetes, hypertension, and a stable angina, you want to replace Zocor with a high intensity statin. Lipitor 40 to 80 mgs or Crestor 20 to 40 mgs is what's going to be appropriate for choice D. So if you chose D, good job. Choice C, absolutely need to discontinue a PDE5 inhibitor with an organic nitrate. As you know, there can be marked vasodilation and hypotension. Choice B is also correct. With a history of MI 2 years ago, this is a definitive or a definite indication for long-term antiplatelet therapy. And since there's no aspirin allergy, this is a great choice. If they had an aspirin allergy, we could recommend a phenylpyridine such as clopidogrel. Does anyone know the brand name for clopidogrel? Put that into the chat. Choice A is also correct. TZDs, including pioglitazone, have been associated with fluid retention, which can exacerbate or lead to CHF. So because this patient is in class 3 heart failure, class 3 and class 4 pioglitazone is contraindicated. Actose discontinuation and metformin initiation is appropriate. If you answered Plavix or Placid, I know about autocorrect NG. I accept your answer. Great job, everyone. Great job. Now, this covers areas 2, which is identifying drug characteristics, as well as area 3, developing or managing treatment plans. So good job on practice question 3. If you chose some wrong choices or were unsure, please make a note and go back and review. Now let's talk about the last practice question. A 56-year-old female with past medical history significant for hypertension, diabetes, and hyperlipidemia present to the ED with chest pain and tightness. While workup is pending, the ordering provider wishes to administer nitroglycerin and asks which dosage forms are available at your critical access hospital. Which of the following dosage forms would be appropriate for nitroglycerin to be administered in our patient? Select all that apply. Choice A, IV. Choice B, sublingual tab. Choice C, sublingual spray. Choice D, transdermal patch. And choice E, ER capsules. It's another good area 2 question, identifying drug characteristics. All right. Anyone else? So let's talk about this one. The correct answer choices are going to be A, B, and C. Now, all five are dosage forms for nitroglycerin. Also know that there's an ointment. And remember with the ointment, sometimes referred to as a paste, needs to be applied with a glove to limit vasodilation to the person who's administering the nitro. However, for this patient, we're looking for an emergency or an urgent situation. So the patch is incorrect, choice D, because it is used chronically. Choice E, being an extended release capsule, would also not work. So the IV admixture would work, choice A. The sublingual tablet, which is also fast acting, would work. And choice C, the sublingual spray, would work. So once again, A, B, and C. Good job, everyone, on practice question 4. Now, that concludes today's topic and practice question. Does anyone have any questions or concerns about the presentation today, the topic, the practice questions, the Naplex in general, the MPJE in general? I'd be happy to answer them if you have them. Also, please don't forget to fill out the survey if you are new or if you'd like to provide feedback. And then also, I'd like to put out to the group that if there are any topics you would like to see covered, feel free to put them in the chat or send me a direct message.